All right, welcome in. If you're a young doc, a resident just starting your very first ICU block, or honestly just someone fascinated by critical care, this explainer is exactly for you. Today, we're demystifying the mechanical ventilator. For a moment, I want you to forget the overwhelming alarms and that dizzying array of buttons. Instead, we're going to treat this machine exactly like an aircraft cockpit that you're about to command. It's all about understanding the physics, the underlying physiology, and the controls you need to keep a critically ill patient flying safely, right up until they can breathe on their own. So here is our flight plan for today. We're going to cover the need for ventilation, deconstruct the anatomy of a breath, look at setting those initial dials, making course corrections with blood gases, and finally, executing disease-specific strategies. Let's dive right into Section 1, the need for ventilation, why we take the controls. Okay, place yourself right at the bedside of a crashing patient. You're the clinician, and you've got to make a rapid decision to take over. Basically, there are three core physiological failures that force our hand here. First up is hypoxic failure. This is where the lungs simply cannot oxygenate the body adequately, and that threatens irreversible organ damage. Second is hypercapnia, meaning the body is retaining dangerously high levels of CO2 that it just can't clear. And third, we have an ineffective drive to breathe. Now, this is a neurological failure, maybe from a severe brain injury or spinal trauma, where the chemical signals telling the body to take a breath are completely severed or impaired. When literally any of these happen, we have to step in and become the patient's respiratory drive. To truly master this machine, you have to understand the physical mechanics of what you're doing to human tissue. I love this analogy. Imagine a balloon sealed to the end of a straw. When you blow air through the straw, it must go into the balloon. The ventilator creates a completely closed system. When you push air in, you are increasing both the volume inside those delicate alveoli and the pressure against their walls. And, well, as we all know, too much volume or too much pressure is going to cause a balloon to overstretch and pop. Our number one rule in the ICU is avoiding that exact trauma. Moving on to Section 2, Anatomy of a Breath, Deconstructing the Cycle. When we break down the mechanics, the respiratory waveforms map out four distinct phases of a mechanical breath. First up, the trigger phase initiates the breath. This is either prompted by the patient's own effort or, if they're out, by the machine's timer. Next is the inspiratory phase, where air is actively pushed into the lungs. Then comes cycling. Cycling is the exact split second the machine decides to stop inhalation. Finally, we have the expiratory phase. Crucially, exhalation here is totally passive. A valve simply opens up, allowing the higher pressure in those full lungs to vent out naturally into the lower pressure of the atmosphere. As you monitor these phases, you're generally going to see two main types of breaths. Spontaneous, or assisted breaths, are triggered by the patient when they attempt to inhale, and then the machine provides a helpful boost of pressure. Controlled, or mandatory breaths, on the other hand, are entirely dictated by the ventilator settings, completely regardless of what the patient is doing. The ultimate goal here, especially for conscious or semi-conscious patients, is avoiding patient-ventilator asynchrony. You absolutely never want the machine aggressively pushing air in right as the patient is desperately trying to breathe out. All right, Section 3, Setting the Initial Dials, your pre-flight checklist. When you walk up to a modern ventilator, the control panel interface in standby mode is just waiting for your commands. As a clinician, your primary job is translating complex physiological needs into these specific dial adjustments. You are literally the bridge between the pathology happening in the bed and the computer system running the show. Listen, if you remember absolutely nothing else from this entire explainer, hammer home this golden rule: 6 to 8 milliliters per kilogram. That is your safe tidal volume, and it absolutely must be based on the patient's ideal body weight, not their actual weight. Lungs don't just magically grow larger when someone gains weight, right? Using lung protective strategies by keeping tidal volumes in this tight, strict range is non-negotiable. It's exactly how we prevent that balloon from popping and causing ventilator-induced lung injury. Now, aside from tidal volume, you're going to need a safe starting point for takeoff. So, here's a rapid-fire baseline checklist for most of your adult patients. Set your PEEP, that's positive end expiratory pressure, at 5 centimeters of water. That keeps the alveoli from collapsing. Set the respiratory rate between 14 and 20 breaths per minute. And, if you're in volume control, you'll set your inspiratory flow rate to 65 liters per minute with a decelerating pattern, meaning the flow peaks early and smoothly slows down as the lungs fill up. Which brings us to Section 4, Adjusting to blood gases, in-flight course corrections. Once you're flying, you rely heavily on arterial blood gases, or ABGs, to tell you if you're actually on course. The crucial concept here is the direct mechanical cause and effect relationship between the dials we turn and the CO2 the patient blows off. If your ABG shows respiratory acidosis, meaning a high pass CO2, you need to increase the respiratory rate or the tidal volume to eliminate more of that CO2. Conversely, if you're seeing respiratory alkalosis, which is a dangerously low pass CO2 from hyperventilation, you must decrease the rate or tidal volume to allow the CO2 to safely build back up to normal levels. You are directly driving their pH balance. But managing CO2 is really only half the battle, right? We also have to combat low oxygen, or hypoxemia. When the PA2 drops, you basically have two main levers. You can increase the FiO2, which is just the sheer concentration of oxygen delivered, but beware, prolonged high oxygen is incredibly toxic. Your other, often more powerful lever is increasing PEEP. By raising that baseline pressure, you stent those balloon-like alveoli open wider, which increases the surface area for gas exchange without needing toxic levels of pure oxygen. Finally, let's look at Section 5. Disease-specific strategies, emergency maneuvers. A standard pre-flight checklist is great, but it won't save you when you hit severe turbulence. In the ICU, you're going to face vastly contrasting approaches depending on the specific pathology. Take a severe asthma patient, for example. The primary problem there is trapped air. You must use a slower respiratory rate to give them plenty of time to exhale fully alongside a low PEEP to prevent dynamic hyperinflation, which is also known as auto-PEEP. On the complete opposite end of the spectrum is ARDS, or acute respiratory distress syndrome. Here, the lungs are incredibly stiff and prone to total collapse, so you must use aggressively high PEEP to force them open, combined with very low tidal volumes, around 4 to 6 mL per kilo, to protect the fragile tissue from tearing. Now, when standard lung protective strategies fail an ARDS patient and life-threatening hypoxia sets in, you have to follow an escalation rescue algorithm. Step 1. Administer a neuromuscular blockade like cisatracurium. This completely paralyzes the patient and eliminates any asynchrony. Step 2. Attempt recruiting maneuvers and prone positioning, literally flipping the patient onto their stomach to recruit dependent lung regions. Step 3. Advanced alternative modes like airway pressure release ventilation, or APRV, and bring in inhaled adjuncts like epoprostenol or nitric oxide. And finally, Step 4. If they're still failing despite all of that, it's time for an ECMO referral to oxygenate their blood outside of their body entirely. We've covered how to take over, how to set the baseline, and how to execute emergency maneuvers. We can master the dials and the waveforms all day long, but I want to leave you with this provocative question to think about. When is the exact right time to let the patient fly solo and turn the machine off entirely? Because the ultimate goal of mastering this life support machine, and honestly the true test of your clinical judgment as a doctor, is knowing exactly when the patient's lungs had failed enough that they no longer need your hands on the controls. Stay curious, keep studying those waveforms, and I'll see you on the wards.